Hello everyone, this is Mr. Matus, and for today we're going to discuss the differences between spinal shock and autonomic dysreflexia. So spinal shock and autonomic dysreflexia are common complications of spinal cord injury, and usually they are also being asked in the NCLEX. So our goal for today is to find out what differentiates spinal shock from autonomic dysreflexia. So remember that spinal cord injury is serious and sometimes fatal. The cervical and lumbar vertebrae are the most common sites of injury. So correct emergency management at the time of injury is crucial because moving the client incorrectly can permanently damage the spinal cord. And of course, one of the most important considerations for patients after a spinal cord injury is definitely knowing the signs and symptoms of spinal shock and autonomic dysreflexia. So let's discuss this topic. So what are the differences between spinal shock and autonomic dysreflexia? Spinal shock is a condition that happens immediately after a spinal cord injury. It is characterized by the sudden loss of sympathetic activity below the level of injury. So what happens here basically is the immediate loss of functions below the level of injury within 30 to 60 minutes up to 6 weeks. And one of the things that you should remember in the NCLEX will be the primary assessment finding in patients with spinal shock, and that would be severe hypotension or a drop in the blood pressure. And also another characteristic is a decrease in the heart rate or bradycardia and warm, dry skin in these patients. So we still consider this as a life-threatening complication of spinal cord injury, and immediate management must be done to save the patient's life. Now, autonomic dysreflexia, on the other hand, is an exaggerated sympathetic response that occurs suddenly also after a spinal shock, and it usually affects patients when the injuries are above thoracic 6. So thoracic 6 means that it includes the T5, T4, T3, T2, or T1 levels, including the cervical spine. And with this location, it makes the person or the patient prone to autonomic dysreflexia. And that's one thing that you have to be aware in the NCLEX, that when a patient in the question has an injury which is above T6, then the first thing that should come into your mind is the possibility of autonomic dysreflexia, because the situation in the question might be focusing on this problem. So autonomic dysreflexia is a little bit different from spinal shock, because what really happens here will be severe hypertension. So in spinal shock, the blood pressure is low, but in autonomic dysreflexia, the blood pressure is actually very high, to the point that the patient will be developing pounding headache, decrease in the heart rate as well, nausea, blurred vision, flushed skin, sweating, goosebumps, seizures, and death. So the worst complication of this condition is seizures and the death of the patient. So this is also a matter of life-threatening emergency. In terms of intervention for spinal shock, in order to increase the blood pressure, steroids will be given, as well as atropine to increase the heart rate, and fluid resuscitation is also an important part of the management. While for autonomic dysreflexia, the intervention will be to immediately elevate the head of the patient, take the blood pressure of the patient, and relieve the cause. Now in the NCLEX, if the question is all about autonomic dysreflexia, especially on intervention, the first thing that you have to think is to really elevate the patient's head, because we want to prevent the possibility of stroke, especially that in this condition the blood pressure is really very high. Now the management also of the patient will be giving immediately your antihypertensives to reduce the blood pressure of the patient. And the antihypertensive, for example, is your Regetin, which is a medication that blocks the effects of the sympathetic nervous system, knowing that your autonomic dysreflexia is an exaggerated sympathetic response. Now, in the NCLEX, usually there will be a lot of questions about what triggers autonomic dysreflexia. And the triggers are usually stimuli that originate below the level of injury. For example, most commonly you have the full bladder, abdominal distension, impacted feces, skin pressure sores, or sexual intercourse. Now you have to be careful a little bit about this because in the NCLEX you might think that the first thing that you have to do when you find out your patient has autonomic dysreflexia is to check the patency of the Foley catheter, or to check for the possibility of impacted feces. But what you have to think first is this is an emergency and the priority is to elevate the patient's head. So that's one thing that's very important that you have to remember. So that was a very quick review of the differences between spinal shock and autonomic dysreflexia. And as an additional information, the other name of autonomic dysreflexia, it is also known as autonomic hyperreflexia. So you should see that the common thing between the two is that your spinal shock and autonomic dysreflexia are both emergency situations, but they have different signs and symptoms, especially when it comes to the blood pressure of the patient. And also you should remember that spinal shock is not the same as neurogenic shock. So that's it, everyone. Thank you very much. If you like this video, please click like, share this video, or you could also visit my website at www.matusnursingreview.com. Thank you very much, everyone.